Antonio German. Okay. Betsy Boyd Flynn. Okay, thank you. I see Betsy on our participant list. Eve Gray.
Present.
Thank you. Gabriel Andine.
Hello.
Thank you. James McGee. Okay. Jamie Osborne.
Jamie Osborne here in transit.
Oh, thank you. Julianne Horner. Okay. Max Kaiser.
Here.
Thank you. Mike Durbin.
Here.
Thank you. Peter Addy. All right.
Hello, I wasn't able to unmute myself. I'm here.
Oh, thank you, Angela. Okay. And oh, sorry, was that Angela or Julian?
Rosemary.
Dr. Rosemary Hemmings.
Yes, I
Wait.
couldn't, it wouldn't let me unmute, so.
That's okay. Zoom likes to be fussy. Robert Cassette.
Here.
Thank you. And Tosh Raman. Thank you. Helen, back to you.
Great, thank you. So for our agenda today, we are going to be starting by discussing a couple of quick things, reviewing our previous meeting, and then I want to let you know about the board's new pause procedure. After that, we're going to be discussing the eligibility straw proposal that Eve and Peter have been working on and presented to all of you to see if it's our final committee proposal or if it needs more editing. After that, we're going to have a presentation from our consultants about the provider reimbursement strategy that was recommended by the joint task force that preceded our board. And then we'll have time for discussion about that as a group. And that should sum up the meeting.
Helen?
Sorry, just a moment.
Sorry,
Peter Merrick
sorry to
has his
interrupt.
hand up.
Thank
Okay.
Oh yeah, I just wanted to mention that my name wasn't called on the roll call, but I am here.
Thank you, Peter. I documented you.
Thanks. And then Kim, is there any feedback from the previous meeting that we need to go over?
That will be on the next slide, Helen. Oh, it's a couple slides from from now. But
this is our orientation slide, just kind of where we are in the process. Our job is to review the existing plan design from the task force, give feedback to those, and then as we come up with straw proposals, bring those up to the board for approval before we move on. So go ahead. And here's where we are in May, starting to talk about benefits and eligibility and moving into provider reimbursement. Okay, next slide.
here's our feedback. So Helen, we can either read it out or we can let folks on the call read it themselves silently.
Yeah, so regarding the long-term services and support straw proposal, we agreed on creating a subgroup. There was a naming problem there, but according to the board's policies, it wouldn't be a task force. It would be called a subgroup or subcommittee. So we need to work on the definition of long-term care, who would qualify, the services provided, and how it would be contained. That has not happened yet, but we are working on that at the board level to set up that subcommittee. The behavioral health straw proposal, some feedback was getting clear differentiation between housing supports and residential mental health services. And then regarding the eligibility straw proposal, we had a subgroup of folks working on that, and we'll see the results of that today. And then we did some brainstorming for provider reimbursement. So in your meeting materials, we've copied the new board policy that I just wanted to let you know about. We're calling it a pause procedure, and basically the purpose of it is to let everyone know and make sure that everyone feels comfortable with the idea that anyone on this committee at any time, if you are uncomfortable with the conversation, if things are getting heated, if it feels like we're being unproductive, we encourage you to request a pause from the chair to either have everyone step back and move on the agenda, or to clarify the purpose of the conversation, to make sure that everyone's voices are being heard. We wanted to set up a formal structure by which if the conversation is seeming unproductive because it's getting heated, to please interrupt the chair for a point of order. You can just say, point of order, chair. I feel like this is getting personal, or I feel like we need to step back or maybe move on. I would encourage all of you to have the confidence to do that. And it hasn't come up, I don't think, so far in this committee, but in case it does, please know that you can do that. You can read more details about it in the meeting materials. Okay. And now I will be handing it over to Eve and Peter to go over the eligibility straw proposal they've been working on.
Are you able to pull it up by any chance?
Yes, I will work on that. You talk amongst yourselves for a moment.
I guess, Peter, do you have any gestalt overall thoughts to share while we're waiting for that proposal?
Not exactly. Yeah, I think you know, we did our best to come up with something that sort of represented the discussions that we've already had as a group, and consider some of the sort of more complex questions that came up during those discussions. And yeah, I think you know, we're still left with a few questions that we weren't, you know, completely able to answer, but yeah, hope to have some more discussion today.
Great. Well, maybe I can start by running through these, but please interrupt me
Cool.
as there are things that I don't cover. So who is covered? We thought about how to determine whether someone was a resident or not. And one of the example documents that was sent to us suggested that maybe using greater than half the days of the year would be that someone intends to stay greater than half the days of the year. Obviously, if you're moving to the state in November and it is your intent to stay half the days of next year, you would still be considered a resident. So it does appear that some kind of documentation is going to be required, and I think Helen can answer more questions about that as needed. Apparently that is a Medicare, Medicaid rule. But we do recommend that there be specific kind of carve-outs made for both seasonal workers and then, of course, people who are unhoused, who may not be able to provide proof of residency. We need a procedure for. Consistent with the task force's recommendation, no waiting periods for benefits, and that there would be enrollment available when you move to Oregon or when you access care. I know that there's been some conversation about how doable that is for providers to enroll people when they show up. So there may need to be some additional, maybe, I don't know if operations could talk about that, how to make that happen. Minors, this one was interesting because it seemed like it made total sense to just cover everyone in the state as an individual and have minors just be a part of the plan as individually covered. And then we got to the part where students leave Oregon and study in another state and their parents are still claiming them on their taxes. And it's like, well, those students are no longer residents of Oregon. And if you cover them as individuals, they're not residents. And so how do you connect them to, there needs to be some procedure to keep them connected. Initially, we had thought that maybe there would be a taxation structure, like a family coverage structure, where a parent could continue family coverage, which would pay for that. I'm not sure whether that's workable or not, or whether we as Oregon just say, if you are studying full-time out of state and you're claimed on the taxes of your parents, that you are still qualifying for Oregon coverage. That gets really tricky, because when does that student become no longer a resident of Oregon if they decide not to move back? So anyway, that was actually the point where it got complicated. To talk about how minors were covered was actually not in minors at all. It was in those 18 to 26-year-olds. Go ahead, Helen.
Wouldn't it be the case that we would just follow the ACA rules in that parents are allowed to claim children as a dependent for purposes of healthcare until 26? I mean, that was what the ACA provision stated. And so whether the parents are in Oregon and the kid is out of state, or the parents are out of state and the kid comes to Oregon for college, I would think that they're still covered under whatever plan their parents have, including, they would be treated as a, if they were as a traveler, the same provisions traveler. So their parents are here and the kid's out of state, they would get care wherever they are, and then that would get billed to the Oregon health plan because they're still a dependent under their parents. Wouldn't that work? Is there a problem with doing it that way?
I think the question is just in financing it. Because today the parents would pay for family coverage and the employer would pay for family coverage under a commercial plan. Medicaid, I'm sure, works differently, but there would be a separate compensation structure that would support the continuation of that individual on that particular insurance plan. And here, the person's moving out of state. They're an adult now. They no longer meet the residency requirements, but we're saying that we'll cover them. And there's no real structure to continue paying for them unless the parents are paying some fee. Go ahead, Peter.
My understanding of like technical residency for college students is that as long as they are being claimed as a dependent by their parents in a certain state, then they continue to maintain residency in that state, even if they are, for technical purposes, living more than half the year in a different state. Maybe someone can jump in on that. I see Betsy has her hand up.
I spent 40 minutes on the phone today with a web carrier, Moda, to talk with them about what it was going to be like when my daughter goes to college in Colorado in the fall. And aside from the sort of eligibility, because similar to what's in the straw proposal here, there is a network that you can access for care in Colorado. The question of attribution, and if we're going to continue, like, this is part of where this part of healthcare may butt up against some of the other things we do with healthcare. Would she still be attributed as a patient of her current PCP under a system like this if she's living outside the state? So I think what I'm gathering from Moda is that, and telemedicine makes this yet more complicated. Woohoo! But there's ways for her to continue to receive coverage under the current insurance that we have until she is 26. And I would think we couldn't construct this plan to be anything really other than that, because that would be in violation of the ACA. So the ACA would sort of preclude anything we might do that would be more parsimonious. I hope that was helpful.
Thank you. I think the finance committee is they'll have to talk through what to do with To whether everyone is paying the same amount and kind of all working people are collectively covering minors, or whether there's a separate charging structure for parents with dependents. And so that's probably just a question to pass along.
I think, sorry, I think it's the former, but I wonder if Anya or Janine can weigh in on that question. But I think it's the former, that all the adults in the state just agree to pay for all the minors.
I don't think the minors would be taxed. So it depends on how the structure of the finance committee comes up with, but they're, you know, with it looking like the task force did at payroll and personal tax, it would be hard to tax the dependents.
Yeah, I don't think we were thinking that dependents would be taxed, but today you pay more for a commercial health plan if you have family coverage. So, you know, it depends on whether we're sticking with the structure today where parents pay more because they have a family, or are we moving to a structure where everyone pays for all the kids? And would there be a difference in public perception depending on which way we go?
I think those are great questions, and I don't think the finance committee has gotten to that stage of into that layer, but that's a good point to highlight to them.
Yeah, I agree. It's a good point to highlight. I don't think it's been addressed so far. These tend to be the least expensive people in the system. They also don't tend to be, just to circle back to Betsy's comment, the alternative payment models that rely on attribution are generally centered around Medicare. And so do not include people who, you know, youngsters. And so I don't think that's a huge issue. But the issue of how you embed their cost in either their own taxation or overall, like, sort of subsidization from everybody else who's paying taxes, I don't think has been addressed.
Kim, can we just highlight that as an outstanding issue on the straw proposal? Just like kind of
Yes.
circle,
I've taken
circle
big notes for this. Yes. Thank you, Helen.
And I see a couple more hands. Do you want to cover those hands, or do you want me to just run through the rest of the proposal and then have discussion?
Your call.
Oh, either way. Go ahead. Okay, well, the hands went down, so maybe I'll just.
I think John was going to say something.
Oh, okay.
Yeah, I just have a quick comment that will require further discussion, both in this committee and finance committee. So the complication is, if, let's say, parents or employer cover the children who are studying, say, college out of state, it's the same issue as out of state workers. That if so, this category, for the children who are studying out of state or out of state workers, if they pay tax, they contribute, the complicating factor will be how do they get health care? So that's a very complex issue, need further discussion and need to be resolved.
Thank you. So on to incarceration. We came to that individuals who are incarcerated should have access to the health plan. We also recognize that today the carceral system pays for health care for people who are incarcerated, and felt that it was necessary for us to continue collecting funding from the carceral system as in order to help fund the system as a whole. There was also a recognition that today jails and prisons are motivated to provide healthier environments, because if the health of inmates, or AICs as we call them, adults in custody, if the health deteriorates, that's much more costly to the carceral system than if you have healthy people in custody. So the thought was that maybe there is a tiered structure of payment for carceral facilities to where they could have lower rates that they pay if they demonstrate that they provide healthier conditions for those who are incarcerated. So that was kind of how we tried to balance that. For out-of-state workers, we recommended that in Oregon, that the state contract with a health insurance broker. And for someone who has, someone who has a big national employer, their national employer is going to be contracted with a broker and they're going to just handle that. The bigger concern is maybe smaller mom and pop companies, somebody who comes back and forth over the border. And the hope was that if we had a broker that was contracted with the state, we'd get the economies of scale to have more reasonable rates for out-of-state workers. In terms of exactly, I think it would be ideal if the taxes weren't paid. Wait, what did we say? Oh, no. We said it would be ideal if they paid taxes and that contributed to the broker. But if that's not possible, a subsidy could help with the employer accessing the healthcare from the broker. For Oregonians traveling out of state, there's I think a question here around, I think Peter and I were thinking that there would be a contracted network of providers who would agree to limits to what they charge for Oregon residents who are seeking care outside the state. Because our concern was if Oregonians are traveling and we don't have a network that agrees to limitations on what they bill, the balance billing to our residents will be high. And we didn't feel that we could limit out-of-state care to emergency care because somebody is going to go and get strep throat, or they're going to sprain their ankle, or they're going to have something that doesn't need the hospital. And they're still going to have to access care, or they're going to run out of their medicine. Something's going to happen when people are traveling. So I think this one is one that still needs fleshed out more in terms of, do we have a network with more reasonable rates, or do folks just go to whatever care provider, that care provider gets reimbursed at our rates, which is going to be lower than commercial, and then there's a big balance bill. Dr. Hemmings.
You have this same issue with the college students. I know when my son went away to school, this was an issue in terms of the insurance company and whether or not they had contracts with healthcare systems he went to school at Northwestern, so in Chicago. So, but this out-of-state issue also comes up with your students in terms of them being able to access not just coverage, but healthcare. I think this applies there too.
You're absolutely right.
So my question is, what happens now? You know, if somebody has a commercial plan in Oregon and they're traveling, my understanding is, yeah, they can get care anywhere. And then you're right, there is some balance billing if the, coverage, if it wouldn't be paid for completely, but they can charge what they will charge and then, seek reimbursement from the Oregon plan. And then there will be some balance billing. I don't know. I mean, it would be good to have a network, but you can't also, people are going to go where they're going to go. And I can't imagine that there's a network that would sort of cover the whole country in any reasonable way. I don't know. I don't know if I can see the benefit of having a network, but I can't see how you get people there if they're not in state. You know what I mean? So,
my commercial plan covers the First Health Network, which has providers in every state of the country, and they agree to charge lower rates if you go there. If you go to an out-of-network provider, absolutely, you're hit with the big balance bill.
I see.
Oh, go ahead. There's a few hands.
Hi, Helen. So if I'll jump in, people may not know, I actually have just been spent the past 5 years working at a regional health plan. And so I have a lot of insurance background, actually mostly in Medicaid, Medicare, not so much commercial. But I think that what will help the conversation is to be really specific when you're talking about a national network, if you're talking about a network of providers or a network of insurance of health plans, because that's usually what, because of course, especially for small health plans, they certainly don't contract all across, but rather than part of their coverage will be, all right, you don't have it through, let's say, Pacific Source in California, but you do have it through a national provider network, or excuse me, national health insurance health plan network. And so I think just when people are talking about it, to make sure what they're speaking about will kind of help the conversation.
Mimi, do you have recommendations for how we would word this section?
Well, I think yes, just specifically when you are talking about a national, Oregon's Universal Health Plan should contract with a national network that provides in-network coverage. So I don't think that it's clear right now if you're talking about a health plan or just say Kaiser all across America. So I think just being specific about that and how that might look.
Mm-hmm.
Go ahead, Betsy.
Yeah, I would agree with what Mimi just said. That again, what I learned this morning is that MOTA contracts with Aetna for a network of providers in other states, and so there's in-network and there's out-of-network. But a reasonably savvy consumer not pursuing emergent care should be able to pull up an app on their phone, it seems to me, and find an in-network provider. And understanding that folks who are currently covered by Medicaid are also travel out of state, I would think that if you're going to have balance billing, we should probably introduce some concept of means for that, so that if a person who has a lower income travels to another state and has a ghastly but not emergent problem, they're not hit with a gigantic balance bill because they weren't able to find an in-network provider that, a bill such that I might be able to pay or my daughter might be able to pay because of our circumstances.
So it should be an insurance network then, is that what I'm hearing? Like when we talk about,
yes.
Okay.
Yeah.
And then I had a comment in there, I'm not sure, I can't read it because it's little, but I had a comment in there about, that folks, so we already have that system within the plan of like a sort of a two-tiered system of folks who would otherwise qualify for Medicaid for various reasons, and they would be exempt from any balance billing as they are now. That's not allowed under Medicaid. So that would persist.
Chenwei?
I just want to add one more complications. The people affected will be relatively small, but still we need to include that. That is people travel overseas, out of country. And I suggest one option we might consider. For people who travel out of state within the country, ideally we might find a national insurance network that the Oregon Universal Health Plan contract with them to help take care of people who travel out of state or people who are eligible and cover and pay tax but live out of state. So that for the people travel out of state. And then for people travel overseas, as well as people who travel or live out of state but were out of the network. Let's say we have a contract national network, but out of the network area. One option, some other country like Taiwan, they did, is they set a reimbursement cap. And so people can get reimbursed, but usually they have to pay, particularly out of country. They have to pay out of pocket themselves, but then they get receipt and they get reimbursed with a cap. And so that's one option you may consider, kind of a dual track. Either you are under the national network, or if not, then we set the reimbursement cap. People get reimbursed.
Mm-hmm.
Hey, thank you. And this may be repetitive, but I was just in case of a process,
You're super quiet for me. I don't know if you are for
Yeah.
others.
Oh, sorry about that. Can you hear me now?
Barely.
Oh, no. I apologize for that. I'm not sure
There
what's
you are.
happening.
There you are.
I'll get very close to the computer. As we work through these, these are questions that are outstanding and wondering how, and I'm wondering what we can do investigation as far as with staff support. And just curious, Helen, to put those forward, and put a pin in this and bring that back so we can be more educated on that decision making. And then also just that pin that goes to the Finance and Revenue Committee. These are things that are going to be dials that we're going to be moving in and out and thinking about decisions, down the road, definitely. And, these are placeholders. So, I think just curious, there are ways to do that, to look at the insurance network broader throughout the country. And as far as people getting insurance when they travel overseas. So I was wondering, just a process like, as we bring these back. And I'm sorry, this may have been covered. I was late, so I apologize for that.
Yeah,
Yeah.
I think, our goal here is to come up with our best guess at a proposal, right? And it's ultimately, this committee is not making the decision about these eligibility requirements. We're just making a recommendation to the board, and then the board would give that recommendation to the legislature, and the details, I think, would be worked out through the legislature and the state agencies that are involved. So I think ultimately we don't have to come up with a final decision. We just have to have thought about this and make a recommendation, right? So we won't be responsible for like doing the ultimate deciding. So
yeah, just as we come to that, and ideally, I would suspect we want to define that as best we can, when then
right.
we pass that off to the main to the main board and then to the legislator. So just wondering, is the idea that at the next meeting or two, we'll hear back more on these specific questions so that we can find that better?
Yeah, I absolutely. I think that we certainly, as the staff, can certainly take on sort of all of these questions, mostly about, regarding out of state, but also around international, and come up at least with a list of what's currently, what most practices are, and certainly what's happening already in Oregon, and then in both, commercial and governmental lines, and then also what some other countries do as well. So we can come back with a kind of a report that at least gives options, and as much as possible, we'll try and get, cost assessments in there too. That may be a little bit longer.
Thank you.
Should some of these issues be on the radar of the operations committee as well?
Absolutely.
It's all connected, as it turns out.
Yeah. Kim, if you would help me by making a note. So we have a process at the board where committee chairs pitch questions to other committees. So like, what do you want to ask other committees, or what do you want other committees to know about the work that you're doing? And so this could be a question that we ask the operations committee and frankly the finance committee too, to say, hey, we're struggling with this piece. We want it on your radar too.
Okay, so what we proposed for non-resident students was a tuition, something added to tuition to pay for it. They are living here at least 6 months of the year in most cases. So according to the very simplistic definition that we did at the beginning, they would be residents. Now, I suppose we could consider them not residents if they're claimed on their parents' taxes in another state, but that could get really complicated to track too. So we propose that it be a part of what schools charge, but certainly happy to receive feedback on that. And I think the last two we've kind of already covered: Oregon students in other states and out-of-state retiree health benefits. Essentially, Oregon students out of state would have access to whatever the insurance network is that we come up with. And then out-of-state retiree health benefits would be the same process as out-of-state workers.
Eve, if I could just jump in on that one, I think there was still a kind of a big question about the retiree health benefits. If they reside in Oregon at least half the year, obviously they're still covered, but you had some comment in there about when folks retire and move permanently to another state and they have sort of vested benefits with their employer that to get health coverage in their retirement. I think that's a very big question. Like, what do we do about those folks who don't live in Oregon at all anymore, but had as a benefit health coverage after retirement?
Yeah, I think something that we had discussed was the potential for the same state contracted broker system that we had kind of conceived of for, you know, small businesses that may want to provide coverage to out-of-state workers. That same system could potentially be applied to businesses that want to provide retirement health benefits to employees that lived in Oregon while they were employed, but then decide to retire out of state and are no longer Oregon residents and therefore wouldn't be eligible for the universal health plan anymore.
Mhm.
I see Dr. Humming's hand is raised.
Yes, it's been a while for me, but don't most universities require that students have health insurance in order to attend? So if that's the case, how would this, and I think some of these schools usually have an option for, I know at my son, an option for students to enroll in an insurance plan that the university contracts with, or has an agreement with. And where here it says there should be a fee or tax applied to non-student tuition to defray the cost of care. How does that affect the university's current plan, you know, as it relates to covering students?
I think what we were envisioning is that the new state law will be that you can't hold your own insurance contracts. So, schools wouldn't be able to provide that anymore. They would have to, I think, utilize the state networks of providers in the state system was, I think, what we were envisioning.
Oh, okay. All right.
Yeah, so our understanding was that currently, if you are an out-of-state student or even an in-state student, and your university does have a, you know, kind of a contracted health plan like you were just describing, that you would have, you know, some sort of fee added to your tuition to pay for your kind of school health plan. And so this is kind of essentially saying, instead of that scenario, now all we have is the universal health plan. And so if you are an out-of-state student, then you would kind of pay a similar fee on top of your tuition, some sort of fee or tax, and then, you know, be enrolled in the universal health plan.
But that's only if you do not have insurance from your home state under your parents, correct? Because you're not asking them to be dually covered, are you?
So I guess that gets to the point on care for visitors. So we certainly could look at if the process for a provider seeing a non-resident of Oregon, that we recommended that they would build a universal health plan and receive reimbursement at their normal rate, and then the state would seek reimbursement from that person's usual source of coverage. So it's really a question on administrative burden at the state level, I would think, in terms of, do we require non-resident students who are here 6 months of the year to utilize the universal health plan, because then we don't have to bill their insurance from out of state or worry about balance billing them? Or do we treat them like any other visitor who comes and needs care? Go ahead, Anya.
Yeah, I was just going to say, I'm not sure, I should know this, but I'm not sure why colleges and universities require students to have coverage. And so it would be worth looking into whether that's somehow linked to federal law. It's so universal that I kind of think there might be a requirement under federal law that they do that. And so I would just want to make sure that if you were switching it to a requirement that students participate in the Oregon plan, that that was compliant with whatever they are supposed to do under federal law.
I think we might have a hard time making the argument for kind of unilaterally requiring non-resident students to enroll in the plan. You know, kind of purely for I'm just envisioning a scenario where the parents have you know, an employer sponsored plan where they're able to get free health coverage for all of their dependents, and then their, you know, child decides to go to college in Oregon, and now all of a sudden they have to pay the, you know, additional charge on top of their tuition for the Oregon health plan instead of using their free kind of employer dependent sponsored coverage. So I wonder if there's, you know, the potential for us to offer the you know, the universal health plan to non-resident students that don't have other coverage but not require it for all students, and require that they kind of drop whatever existing coverage they might already have.
Yes, I would just say, and this comes from being a parent of college, multiple college students, the colleges require proof of insurance coverage. And you will automatically, if you do not provide that, then something is tacked on your tuition and then your child is enrolled in the insurance. So that is a potential that is already happening at the university level, that they're sort of documenting proof of insurance coverage. So I don't think that the intent was to have dual coverage.
Okay. So that one needs to be massaged a little bit, it sounds like, in order to allow for out-of-state coverage. It'll be interesting though, I mean, with no copays and no deductibles, and it may be cheaper for some parents to sign their kids up for the Oregon plan, depending on what's going on. And go ahead.
However, the problem, just is from my own experience, the problem comes in when the student returns back to their home state, like for the summer, for example, right? You know, the parent is not going to drop their kid from their current coverage while they're away. Yeah, it gets tricky. Massaging this, yeah, I agree.
Go ahead, Peter.
Yeah, I think it sounds like basically the language just needs to be tweaked a little bit to essentially say, you know, if you have existing coverage as a non-resident student, you can keep it. If you don't, then you'll be signed up for the universal health plan and some sort of fee or tax will be added to your tuition. And for those students, you know, it sounds like we're pursuing some sort of national network. So hypothetically, those students that don't have coverage through their parents and are kind of forced to sign up for the universal health plan would have some sort of option for when they go home over the summer to still seek care.
Okay. So the qualifying provider is very simple. It's the same as what the task force recommended. So I don't think we need to. So I think that's everything. Peter, what else did I miss?
Yeah, I think one thing that we had some questions on that I don't think we've discussed yet today was we wanted to make some sort of carve out for seasonal workers, with the understanding that many seasonal workers probably wouldn't meet that standard of over 183 days in Oregon a year. We weren't entirely sure what the best avenue to kind of accomplish that carve out would be. And we kind of felt like we needed sort of the input on of someone who had a little bit more expertise with that population. For example, how long are folks usually staying in Oregon if they are seasonal workers? What would be kind of a reasonable requirement for documentation for those kind of folks if there is a carve out, things like that. So that's something that we felt like we needed a little bit more help on.
So the rest of the straw proposal is fairly formulaic, I think. But happy to accept any other questions, revisions.
I wonder if Angela, if you could speak to the question of seasonal workers and what proportion of them are migrating through the state versus in the state year round. Because you're at One Community Health, is that right, Angela? She may not be available, but that would be worth asking her. And Eve, are you at a FQHC too, I think, aren't you?
Yes, but we don't have a high population of seasonal workers. That there are a few hands up. Maybe we can start with Tony.
Yeah, no, thanks for the questions. I mean, I think, I can speak, I've been working at a rural migrant farm worker clinic for the career. I think, I can't speak anecdotally, though. I think what we need is some further data investigation more broadly about that. I wouldn't want to offer, what I've observed in my clinic population alone. I think we should see, some estimations that maybe OHA has regarding, how many total people identify as seasonal migrant farm workers. And I think thinking through some of the stuff we've discussed before regarding identification of residency and defining what that time frame is might be productive for this conversation and say, do we think that is 30 days, 90 days, can somebody demonstrate that they have a position here? Those might be some questions that might help offer some more clarity around this issue.
Add it to the list. We'll look into that.
Head Angela.
Hi, sorry, I had a problem unmuting. I don't know, yeah, it wouldn't allow me to unmute, but I agree that there is some data. I think documentation is exactly what we struggle with that population. So that is an interesting question, like even when, I know for us though, yeah, it is very seasonal. It depends on the fruits and how long. For us, we see a lot of folks that come from California and they're here for even just a month or two, but we've noticed that the orchardists in our area are trending towards H-2A workers now too. And so those have contracts with periods of time. And so yeah, there's a little bit of fluctuation in there, but I agree with what Tony said. Getting some data too would be helpful.
I wonder, Angela, do you have who would have that data? Does the Commerce Department or the Employment Division, who knows that?
I'll just say OHA, sorry, this is the other part of my work history, was in public health for 10 years. So OHA definitely has that kind of data. So that's very accessible.
Okay.
Yeah.
Yeah, and I would say that in recent evaluations with the HOP program, that there's been a great deal of investigation and clarity around that we could probably draw upon the staff. I don't want to call out if Devin is on this, but I know, I know the staff there and appreciate just us taking a look at that.
Thank you.
Any other comments or feedback about the whole eligibility proposal? Eve, I got the impression that you were wrapped up. Is that accurate?
Yeah, it looks like Jamie has a hand raised too, though.
Wait, I can't see hand raise. I am sorry. Thank you for calling it out. I can't see any of the hands.
No worries. I don't have much to add to what our last two participants said. We do have a large community here that we service well. I think the HOP is a good call out. I also think that there's going to be increasing resistance to identifying oneself as a migrant worker in the current environment. And so that may pose some challenges. I'm also wondering about the idea of if there is a common geographic area that includes more than one state, could we have some agreements with Medicaid and neighboring states to share coverage for when workers are moving through? As kind of as sort of a makeshift workers' comp network for agricultural workers that would rely on the Medicaid in the states that are close enough geographically to share the benefit that those workers bring to our community. I think those states should be willing to help support their continued health.
That's a great idea.
This is Janine. I do think though Medicaid you're not allowed to use the Medicaid dollars for non-citizens unless you have a specific. I mean, for Oregon, we pay out of our state-only dollars, not federal dollars. So if they go into Idaho, it does not cover people who are not citizens in their Medicaid program, and their Medicaid program is much smaller than ours. They are eligible for Medicaid in that if they're eligible for Medicaid in that other state, if they fit the parameters of that state, then they can get it there, but they have to apply. So there's a lot of work around that, how that would be sorted out. I mean, I think it's a grand idea, but I don't think you can use Medicaid dollars for it, at least in the current regulations.
There's I'm blanking on the name for it, Janine, the federal dollars that are used for emergency citizen wave. COWAM? What is that, COWAM?
COWAM, yeah.
Yes, citizen
so
alien
some
waiver.
states have a much more limited COWAM than Oregon's. Oregon has been pretty progressive in this, but there are limits as to what, a lot of that was around paying for deliveries and not necessarily paying for prenatal care. So it depends on the state as to how they use their COWAM authority.
Is that something we need to add to the list of waivers, federal waivers to look into, is COWAM or not?
Well, it'd certainly be part of the, because a lot of the advances, is that we at least tell the state feds that we're doing this in the state and how the dollars are allocated. So it probably falls into your 1115 discussions.
Okay. Anything else? I do these meetings on our government issued teeny iPads, so I can see like 3 people out of this whole gathering because it's like this big. I'm really sorry.
I will return the meeting to you, Chair.
Okay. All right, so I think good timing. We were supposed to end at 2 and it's 1:58. Excellent. Thank you so much to Eve and Peter for all your work on this. I really appreciate it. We have a bunch of notes. The staff will work on sort of clearing up some of those additional questions, and we'll bring it back one more time in June to see where we are. So now I'm going to, we're gonna take a break. We're already at break time, so we have a built-in break. Oh, sorry.
No, we're not there yet. Sorry. Back to the grindstone. Your break's not till 2:50.
2:15. That is a break. Okay, great. Do we have time for the HMA presentation? You got about 20 minutes. Yeah, we can do that and then take a break after that.
Well, we have follow-up on behavioral health and long-term support services for our proposal.
Sorry,
next
I'm going back. I'm using my laptop because I connected. Apologies.
So, Kim, do you want to take over and share slides, or just have me continue to share the slides, or bring?
Amy, you can continue to share the slides because I recapped it on the next slide what the main changes were to both of these proposals.
Fantastic.
And then this is both of us. Kim, do you want to take this or do you want me to do it?
I can take it if that makes it easier.
Sure.
I know that some folks are joining while in transit, so I'll go ahead and read these out. So last meeting, we received the behavioral health and long-term services and support straw proposals. Those were able to go to the board during their March meeting for their feedback. And so based on committee member feedback and board feedback, a couple of main changes were made to both of those straw proposals. The behavioral health straw proposal, we believe, is in pretty good shape. The board had, positive thoughts about it, and it seems like it would be fairly easy to carry forward and bring to our consultants and get continued board buy-in on those. The main changes to the straw proposals that you'll see in your meeting materials are our colleagues at HMA added a concise summary of those recommendations. As we go forward with proposals, I highly recommend that folks consider that concise summary, adding that concise summary to straw proposals. We also described patient-centered primary care homes, PCHs, and their sort of summarized relationship to FQHCs and CCBHCs. And then there was also a very detailed and specific clarification of the services and provider types that we believe would fall under the proposed coverage for behavioral health benefits. So please read the updated proposal when you get the time, if you haven't already. And for long-term services and support, similarly, our colleagues at HMA added a concise summary. This committee had asked that we define LTSS more specifically, and so the DHS definition was added in. And the biggest action out of this one, since it's not quite ready for go time, is that, as Helen pointed out in the beginning, we are recruiting for a subcommittee, mainly to operationalize what is meant by long-term care, who will qualify under the UHP, how the services will be provided, and how we might implement a plan that really helps with cost containment. And this piece should be done with the cooperation of the Finance and Revenue Committee. So the Finance and Revenue Committee, whoever participates in the subcommittee, should be prepared to work closely with the Finance and Revenue Committee also. Helen, would you like to add anything else?
Oh, that was great. Perfect.
Okay, thank you. And then Helen, I'm going to let you, as the chair, be in charge of recruiting that subcommittee.
So it wasn't clear to me. I'm not sure if we have decided if the subcommittee is a group of folks from this committee or if it's new people. Certainly, if we have folks on this committee who are interested in that, you'd be more than welcome to kind of keep working on that. I sort of had the idea too that we might want to pull in some folks with specific expertise in this realm, and we could add them on. The board can appoint new members of the committee or subcommittee at any point in time. And so if folks here want to work on that, we would love to have you involved, and know that we will specifically be going out and looking for people with expertise in this area to help us out with that. Does anyone have any interest? And you'll have to say your name instead of raising your hand because I can't see anybody.
Robert has his hand up.
Who's that? Robert.
Yay.
Yes. Well, no worries. Yeah, I would say that our recommendation was more or less what you laid out, that this be composed of people with specific expertise applicable to the area.
So are you volunteering to still be on it, or do you?
I would need to understand a little more about what the commitment time wise is to that.
Mhm.
But I'm willing to talk about it.
Yeah, I'm almost imagining that it would be separate enough from this group that, you know, if people wanted to branch off, like this is a big group and we did that on purpose. This is a complex part of what we're trying to do. And so I think what we imagine over time is that this committee may sort of break up into sort of interest areas as we get a little further along and have more and more specific questions that we need to hone in on. We still can convene as a huge group, but it's not contrary to our plan that, you know, some folks might just want to say, okay, I get a sense of what we're doing. This is the piece that really interests me or that I can really bring something to. I might just want to focus on long-term care, or I might just want to focus on the behavioral health details, or I might just want to focus on provider reimbursement. Like that's going to be my thing. You know what I mean? So we might consider doing that. So if you wanted, and this will be our first subcommittee, if others kind of come along, and if you want to be on the subcommittee and the time commitment is an issue, one option would be say, I just want to do this subcommittee and not be part of the bigger group anymore, or you're certainly welcome to continue participating in both if your time allows. So I'll just put that out there.
Thank you.
Kim.
That was helpful.
Sorry, Kim has a hand up.
Thank you. And so for Helen and everybody else's benefit, from a procedural standpoint, the UHPGB policies and procedures states that committees can be continuing or temporary, and committees can be open to non-board members if the board agrees. And so it actually sounds like the subcommittee for both the long-term services and supports and any other group or any other work that we may choose to spin off can be open to members of this committee, members of the board, and possibly other folks who we identify as having really relevant expertise in this area. But just wanted to point out that procedural aspect.
Okay, so circling back, is there anyone who would like to identify themselves as for sure wanting to kind of hone in on the long-term care work and be part of that task force provisionally? You don't have to, you know, once we get into it a little bit more and find out what else is involved, if you're interested and want to work through the details, let yourself be known.
And if you sign up first, you can be the one who sets the time. Just saying.
Feel free to put me on the list.
Thanks, Robert.
Thank you.
Okay, and then feel free, if you think about it and want to volunteer, you can send us an email through the usual channel, which is the info@UHPGB.
So close, Helen. It is UHPGB .info.
We need a acronym, you guys.
UCBS.
We need a super cool acronym.
It will be there. Don't worry. It's on our website. It is findable. Thank you, Helen.
Yeah, so send an email. We see all of those and you can let us know. Cool. And back to the slides. Anything else we need to cover there? No? Okay. So now we'll take our break and we'll do 10 minutes. So it's 2:10. Let's come back at 2:20. See you guys at 2:20. Kitty, kitty. Okay, everyone, it's time to reconvene. The next item on our agenda is a presentation from our HMA consultants about options for provider reimbursement that come from the Joint Task Force recommendations. So I will hand it over to Janita and Anya.
I think Janine is going to start us off. Janine, you there? Okay, well, let's see if I can see her there. Oh, she seems to be not here. So, okay. I will wing it and try to cover what Janine was going to cover. Yeah, so the point of this presentation is to revisit what the task force prior to your incarnation recommended for provider reimbursement. I hate the word reimbursement. I like to use provider payment. But provider, the payments that go to providers under your universal health plan, how should those be structured? What level should they be set at? And what principles underlay how you make decisions about the approach to payment, so the methodology and structure, and the level of payment. And so that is what we're going to present today. And let me just make sure that Janine is not with us yet. No. Oh, she is with us. Janine, do you want to take over? Okay, I'll keep going then. So first, the principles.
Oh,
Um,
hi, sorry, I'm here.
there she is.
Sorry.
Janine, I just gave an intro to
Okay.
what the point of this session was, and now we're on what are the principles.
Okay, so you can go on to the next slide. And the next slides. So the task force had basically 3 main key principles when it came to payment or what they called provider reimbursement. One was to make sure that it was adequate funding so that you had a robust network of different providers, and that was good as much as possible throughout the state, understanding the challenges of rural and frontier areas, of course. They envisioned a reimbursement model with pay parity among providers who serve different populations. So currently, as we'll talk about in a minute, commercial pays better than Medicaid or Medicare, and that's true nationally, but it certainly is also true here in Oregon. So you would get a more equitable care for patients because everyone would be, every person that gets seen would be paid for with a common rate. The reimbursement model would also account for differing reimbursement needs of providers in rural and urban settings and in underserved communities. So as they thought about these key principles, that to kind of align these and balance these, they thought that the public entity that would run the single payer and govern the plan would set global budgets for each region. And that budget would be based on an enrolled membership and demographics, ensuring adequate funds that are allocated in that region to make sure it was adequate funding to cover the services needed for members with complex medical, dental, and behavioral needs. Next slide. So in thinking about that, they moved to think about a sort of a general reimbursement rate as they're trying to align the differing rate structures. Next slide. And is this yours, Anya?
I think it is.
Yep.
The first thing that they did was compare reimbursement or payment across payers in general categories in Oregon. The benchmark, as you'll see, this becomes a theme throughout our presentation. The sort of stake in the ground was, what is Medicare payment? Medicare payment is assumed to be by the Medicare program, by the federal government, to be cost-based and to cover the cost of providing care. You will talk with many providers who say that's not true, doesn't cover our costs, but that's the assumption, and it's kind of it's used as a proxy for cost in the market against which we measure how are other payers paying. And usually, actually always, what you'll find in a state is that Medicaid is the lowest paying payer. Medicare is in the middle, assumed again to be cost, and commercial insurance is the highest. And oftentimes people talk about the cost shift, which is the extent to which Medicaid underpays, and some would argue Medicare underpays, and that gets shifted to commercial insurance. So what the contractors in the last round of analysis found was that commercial insurance in Oregon was paying about 170% of what Medicare pays on average across all services. So that's a very general statement. You'll see a lot of variation between services. We, HMA, have actually done some work in a couple of states where they're trying to implement reference-based pricing, where they try to bring all payers to some multiple of Medicare. And one of the things that you'll see is that that has not only an effect of equalizing payments, but also some redistributive effects. So for example, in Washington, they are poised to implement reference-based pricing based on Medicare, and that will actually result in mental health services being paid for at a higher rate than they have traditionally. Medicaid in Oregon is approximately 85% of Medicare payments. This is actually not as great a differential as you see in some states. I'm working with Vermont right now, and the commercial payments are 300 to 400 times Medicare, so that differential is much greater. Next slide, please. The idea is that the single payer system, that the universal health plan would eliminate variation by bringing the entire system to a standardized fee schedule. So the task force looked at what that should be, trended it forward, and determined that what the standard fee schedule should be, again, pegged to Medicare rates. The assumption in the Optimus calculations was that the standardized fee across Medicaid, Medicare, and commercial would be 124% of the Medicare fee schedule. What's important to know here is that this is a fee-for-service base, and I'll get into that in more detail. But basically, this is saying whatever Medicare pays on a fee-for-service or a DRG basis, again, I'll explain that more later, you would adopt that and pay 124% of that across the entire population of Oregon. And what that would mean, if you were kind of looking backwards at where things were, and now you've got everybody at a fee schedule that's 124% of Medicare, those who are currently paying a commercial payment would see their payments decrease by almost 50%, 45.7%. Medicare payments would increase by 24.3%, makes sense, because we're going to 124% of Medicare. And Medicaid would increase by 39.34%. So there's this leveling across the population of the payments and equalizing of the payments across the population. I see Robert has his hand raised.
Yeah, I just wanted to call out that I haven't read that report, but presumably is based on a snapshot of like the population at some moment, right?
Yeah.
And that we sort of understand that generally speaking, the population is aging. Generally speaking, Medicaid enrollment is increasing as far as I know. So like actually that 124%, if it's based on like a recent past snapshot, if you were to do the same kind of analysis, say in 5 years, you'd likely get a lower number than that because there's a greater proportion of folks enrolled in Medicare and Medicaid. And so just something to kind of note. As far as plans to reevaluate, every so often what that number should be.
Right. And at some point it becomes irrelevant if you actually implement the universal health plan, but your contractor Milliman, who's just coming on board, is tasked in part with updating this calculation and giving you an assessment of, at this point in time, what would it take to bring all payers up to a common standard of payment. Yeah. Okay, next slide, please. So I don't want to get too geeky on you, but I do think it's important for you to understand that there was a lot of language in the task force recommendations that didn't necessarily make a whole lot of sense when I read it, because it was kind of internally inconsistent. It said, we want to pay as a percentage of Medicare, but we want to do value-based payment, and we want to have global budgets for hospitals. In some cases it said regions, in some cases it said. So just want to ground you in, what does it mean to latch yourself onto Medicare, which isn't a bad idea, but I just think you should know that this is the way that the costs of the program will be analyzed are based on what Medicare does today, how it pays, and what it pays. So Medicare pays hospitals on a DRG basis, diagnosis related group. This was a huge innovation in the late 80s, 90s. And I would I'll step back to say Medicare is often the innovation leader, even though lots of people in this country think that that government is not the greatest source of innovation. Medicare remains kind of the leading edge of innovation in healthcare payment, and to a great extent, Medicaid and commercial insurers have followed their lead in terms of what they've implemented over the last several decades in payment change. So one of the biggest sort of most pervasive innovations was this DRG payment, which is a payment for a discharge from the hospital. You get hospitalized for congestive heart failure. There's a payment the hospital gets no matter how long you're there, unless there's a complication or a readmission. But if you have just sort of a basic admission for CHF, the hospital gets a payment. And that means that as a hospital, in theory, you have an incentive to get that person out of that hospital bed as fast as possible. All other payers pretty much have adopted that methodology at this point in time. Likewise, physicians and other providers are paid by Medicare on a system of a fee schedule that has some regional adjustments, but basically is a nationwide fee schedule that is supposed to reflect the resources that are needed to provide every service. These are called relative value units. The methodology is called RBRVS, the resource-based relative value scale. And the idea of this was to provide for a fee schedule that balanced kind of how much do we value all of these services. And at the outset, the idea was to kind of rebalance toward more cognitive and diagnostic skill sets, so primary care and other professions where you spent more time with the patient, you learned more about them, you didn't just do a procedure. The scale got a little bit perverted in the process of getting implemented and got skewed a little bit towards specialists, but it is still sort of the basis for how Medicare pays. And again, a lot of other payers, commercial and Medicaid, latch onto that and use that as a basis for their payments. There's some talk in the task force's recommendations about alternative payment methodologies and being able to do, this, that, and the other thing. I don't want to be a wet blanket, but I do want to note that CMS, Centers for Medicare and Medicaid Services, allows for very narrow deviations from their standard methods of paying. And they created CMMI under the Affordable Care Act, which was designed to allow for more innovation, but still it's pretty like Medicare pays unless you're under a very specific demonstration project, which has to get approved by CMS. So some examples of those are bundled payments, which allow for mostly for hospitals and post-acute providers to get a lump sum payment for something. For example, this has been used mostly around major joint procedures. So hip replacement, knee replacement, a bundled payment across all the providers who are involved in that procedure, from prehab to rehab and the surgery in the middle, get a lump sum payment, and that gives them an incentive, sort of like a DRG, to try to be efficient. Shared savings was the basis for most of what's called the Accountable Care Organization, ACO models, that CMMI launched over the last decade. And that means as a group of providers, you band together and say, we're willing to take risk up to a point. And if we do better on cost and quality than what was predicted for the population we serve, we get to share in the savings. There are also models where they actually got dinged if they ran over budget. Those were not terribly popular. The shared savings models, in my opinion, were pretty weak, although there's a article in JAMA this week about how they actually over time did produce savings. And so that's good to know. And then there are some really idiosyncratic kind of one-offs, which involve all payer payments. Maryland is the best example of where Medicare went into a deal where they said essentially it was like the first of the reference-based pricing to Medicare. Everybody's going to pay at the Medicare price. They've followed that for a long time. Vermont had something of a variation on that theme, but wasn't as kind of rigid about adhering to the Medicare methodology and making all payers belong. So I think Maryland remains the best example of where they kind of tried to do something that might be kind of like what you're trying to do under your universal health plan. Next slide, please. Methodology and structure. I think this goes back to Janine. Before I hand it back to Janine, I just want to say, I don't think you all need to understand all the weeds of this, but I do think for the purposes of having your contractor model stuff, you need to probably just say, yes, we endorse latching on to Medicare as a reference point. And then think about ways that you can innovate around that, because what you need to do is price your plan at this point. And that means you need to set what is the level and methodology of provider payment. And actuaries can do that quite easily. If you say, I'm going to peg myself to Medicare. If you get super creative about, we want to have, global budgets and this variation on the theme, that variation on the theme. We want to have lots of experiments. We want to have, local entities deciding how we spend money. It's going to make it much, much harder for your contractors to price the plan. But it doesn't mean that you can't look at some of that stuff down the road. You just need to understand, is that going to increase your budget or decrease your budget? And with that, I'll hand it over to Janine.
So we'll go into this last section So overall, as I said in the principal slide, the plan would set a global budget. It would be risk adjusted and and would include capitated rates for each region. The idea was in their recommendations that the plan would be the ones holding the contract with the providers, but they would be working with what they termed regional entities who will advise on payment and budgets within a particular region. There was an emphasis, as this committee has talked about, of meeting the needs of behavioral health providers and trying to have some pay parity amongst the providers. The global budgets would be based on enrolled membership and demographics, ensuring adequate funds, as I said before, on complex needs. And then they wanted to expand on the notion of what we currently are seeing today in value-based payment to try to influence and get more value out of their payments. They thought that the regional communities would have some influence over what kind of outcomes they thought were most important in their region, and thus have their payment arrangements formulated in such a way as to incentivize that. Task force did have a discussion on a provider reimbursement model, and as they talked about it, they really felt strongly that institutions such as hospitals should not be paid fee for service, but to have a value-based payment approach or a hospital global budget. And that's about, they didn't go into the nuances as Anya was saying, they just kind of felt like that was the direction that they wanted to move away from fee for service, and particularly for hospital facilities. Next slide. And a lot of the discussion was based on how different care is delivered in rural versus urban areas, and really had a lot of thoughtful discussions about single payer interacting with providers, and currently, especially amongst our existing regional structures that we have in Oregon around our Medicaid program. So many of you are very familiar with this, but currently Oregon has 16 regional entities. There is some overlapping regions, but there are some regions that only have one CCO. The difference here is that the CCOs currently have risk-based contracts with the state, and then the CCO has their own network of providers with whom they contract to care for their assigned membership. And then some providers can be in multiple CCO networks, and some are only in one, depending on which part of the state they're living in. So it was the thinking of what's going on right at currently, and then how would that translate under a universal health plan. So they came up with, I think on the next slide so they talked about that they should be these regional entities, and they would receive, they felt that the groups inside each of the regions of that, so they have global regional budgets. Inside that region, there would be regional groups of doctors, hospitals, and other healthcare providers who would get risk-adjusted capitated payments. They thought they should be risk-adjusted to ensure that there was not any quote-unquote cherry picking of the healthiest patients, and that the regional groups would negotiate how they would be compensated and their rate. But again, the contract would be between the state and the providers, not the regional entity and the providers. So they were trying to allow for a regional variance and shift the burden of cost containment to the regional groups. And they felt that there should be some regulation to ensure the needs of providers who require unique consideration are met, is one of the way they termed it from their provider technical advisory group meeting notes. So next slide.
Janine, I wonder if I can interrupt you for a second. What does that last point mean? Do you have any like details on that? I don't understand that.
I think that what they were, I don't know exactly, because I did go back and listen to their meeting. But they wanted to make sure, I think that providers were, different types of providers were providing similar services should get paid similarly. And then if there were some unique providers that you don't really fit into the usual mold, but are really definitely needed, that there would be some consideration on how they would get paid. So I don't think you would want to pay community health workers at a capitation per se. That comes to mind as, they'd still have some unique providers. But it didn't really fold up with the next slide actually has kind of how that was discussion at the tag for the regional entities, and then how it rolled up when those recommendations went back to the task force. You didn't see as much of a clarity on what that exactly meant.
It looks like Robert has his hand up.
Yep, Robert.
Yeah, sorry, can you go back one slide to this question of yeah. So what that last point means to me is like something that's come up earlier, especially with like hospitals and providers with unique consideration, like when you pay fee for service, then you like pay someone more or less for their volume that they receive, and it's already like differentiated in the Medicare payments, for example, that certain hospitals like critical access hospitals and so on, like you want them to stay open, and therefore you don't want their payments to necessarily go down because they don't have enough volume, because then they might close. Right. And you really want them to be there, and so they pay more based on cost to those facilities already. And that's something that I think applies to providers of all types in all places, especially specialists at times. Well, not really. I mean, primary care as well. If you're in a rural area, you don't have as much volume, and so like you don't want to have to necessarily rely on getting people in the office, since the point is really to keep people out of the office anyway and healthy. So I think there are also unique considerations around providers who like might not be able to generate enough volume to stay in business in a pure fee-for-service type of model, but that are really necessary for filling out the network adequacy in a particular
especially
region.
in the rural and frontier areas.
Especially in rural, yeah, exactly. So another example of unique consideration, say.
Yeah, and I would just say like the critical access hospital methodology is very much an aberration. The standard Medicare methodology these days remains fee-for-service payment. And, that's the sad truth about the American healthcare system. That's where we still are, despite trying to innovate. But yeah, COP payments are a great example of where we said we need access in these areas, and so we're going to deviate. FQHC payments are another example of where like we make sure that those providers have enough, although I'm sure they don't think it's enough. So there are places where we've plugged the holes, but in general, we're still working off of a fee-for-service chassis.
So to sort of summarize, sort of a myriad of things that they discussed is that they felt that the single payer plan entity would pay the providers directly. The rates would be set in partnership with by the region and to account for different healthcare needs and costs in parts of the state. The plan and its board would operate in partnership with this network of regional entities on the provider reimbursement. But they would be different than the current CCO type of relationship. And these entities would be responsible for convening and collaborating with stakeholders in each region, ensuring that the plan is responsive to the unique needs of the wide array of communities across the state. And they would advise with relation to coordination, delivery of care in each region, advise on budgets, reimbursement methods, and capital spending for providers in the region. So it is a different model than currently in operation in Oregon's Medicaid program. It's a little bit of a variation on a few things you see in other states, such as Washington's Accountable Communities of Health, and although they're not as engaged in actual provider reimbursement. And New York State had some of these models, and in back there was a lot of stuff historically in healthcare policy of this kind of making sure the regions had their voice. But it is different than the current CCO, state to CCO, CCO to provider relationship of at least how the payment streams work. And the next slide, I think that might be.
Can I ask a quick question?
Sure.
What's the benefit of disengaging that, like that difference between the CCO model and the proposal? What is the benefit of changing that?
I think that was just kind of like a combination of some folks wanted there to be only one payer, but other folks saw the value of having the regional entity be engaged and involved. So I think this was their way of kind of bringing those together. I don't know exactly. I think they didn't want to have, they're trying to get a lot of the participants in all of these committees and task force wanted to get away from having little health plans, right, in each region, which is what each of the CCOs are, that there would be a true single payer. So I think there's pluses and minuses that you could list on going one way or the other. I mean, the advantage of having someone doing care management and being held responsible for it in a regional area where they're closer to the providers and the patients is one thing versus having it done on a state level that you would have to consider.
To me, it's very confusing. It's sort of, is this an advisory? Like, do you diminish the role of current CCOs and say you're an advisory committee on health resource management within your region? Or is it a intermediary for payment and resource allocation? And I'm not clear on which it is.
Yeah, it seems like kind of a weird middle ground, and then also taking away the incentive of the local groups.
Right.
So it kind of doesn't, I guess to me, doesn't solve either side and just makes it less useful. Yeah. But yeah, I think regions do need representation, and usually works if you have incentives to do that.
Yeah.
Yeah. Okay. Thanks.
Yep.
Next goes in.
See who was next, if it was Betsy or Helen, sorry.
Go ahead, Betsy.
Yeah.
Thanks. And we may be about to get to this in the context of the discussion, so feel free to table an answer to this question. Are we operating on an assumption that there will be a general resorting of patients among existing clinical infrastructure? Or do we imagine that for the most part, people are going to keep going to the same doctor that they have? And I ask that question in part because the acuity, even the age range of a patient population, I'm thinking of the clinic where my family goes, is very different from an FQHC or a clinic that is more of a safety, that serves more of a population that needs a safety net. And I want to be certain that regional variation is, I know this makes it more complicated, but is that granular enough? Or are we suggesting that we're sort of going to toss everyone together and everybody gets to find a new doctor? And yeah, so that's my question.
I don't think the task force really addressed that question per se. I haven't seen any assumptions that, some people are through their Medicaid plan, particularly, are assigned to a clinic. Commercial plans have their own networks of clinics. So if you could say that if you had a universal health plan card, you might have more options on where you might want to go, because everybody's going to be taking, they're all getting paid the same, and they're all getting, they're all part of the same plan. So,
Right.
but I don't think there was a directive one way or the other.
I agree, and I would just say, yeah, the opportunity of paying everybody the same means that they won't have to make, in theory, decisions about which patients they take or the volume of patients they take by payer the way they do now. But I don't think there was any concept that they'd be forced to switch.
I just point out, I think that, part of the transformation we've been doing in Oregon is to build this healthcare team, and that team is more intensive and larger for folks with higher levels of acuity in terms of chronic disease or social health-related social needs. Not everyone needs care that intensive. And so if you have clinics that have been over time specializing their business model and their team to provide that highly integrated, very supportive team-based care, it seems like one of the unintended potential consequences of a shift like this might be that there is no longer, either every clinic needs to do that, which hooray, it'd be awesome if the payment model actually supports every clinic having that, but it's gonna be disruptive in that area. And I don't think until this conversation that had really occurred to me, and I wonder. Yeah.
I mean, it's redistributive, and that
in good ways, and right. Yeah.
Yeah, and that's redistributive usually means disruptive. And if you think of it, who's the losers in this equation? It's the practice that takes no Medicaid, no Medicare now. They're gonna have their payment yanked down to some multiple of Medicare that is not what they've been experiencing.
But the good news is there are 650 clinics that are recognized in the state as team-based, patient-centered primary care homes. So there is a lot at the clinic level, and many of those are FQHCs, and many of them are private practices. So you do have, there is some infrastructure there across the provider networks, but it is definitely could be a shift in the types of patients where the patient will choose to go.
Helen. I'll start by responding to that discussion, which is a really great point, Betsy, and I completely understand what you mean by that. Kind of the way I envision this, might be totally off, but so there's a global budget at the state level, and then the state is giving a global budget to, let's invent 20 regions. There's 20 regions around the state, and each of those 20 regions, they get a global budget. And then within that region, they have some authority to decide how that global budget is distributed locally. But probably what's going to happen is within each region, there will be provider groups of clinicians, which might include just purely outpatient clinicians, for instance, an FQHC, or it might include a group of outpatient and specialists like Providence or Kaiser, where they already are a fully multidisciplinary group. They might vary. Some of them would offer pretty limited services, maybe a small independent practice that just does primary care, or it might be a giant multi-specialty group that can ride the whole thing. Or it might be, to your point, an FQHC that does really intensive wraparound supports social services, community health workers, integrated behavioral health. But each one of those clinical groups within the region would negotiate a capitated rate based on the population that they're serving. So it wouldn't be a straight up, you have this many people, therefore you get this much money. It would say, this is the population we're trying to reach, and this is why we need X amount of capitated dollars as compared to someone else. And so within a region, provider groups would compete with each other on the quality of care they're delivering, and the services that they provide, or the culture, for lack of a better word, of their practice, right? So And then each region would just have to say, look, this is the pot of money we have. We have to figure out how to distribute them among this region. What are our values? Who are the folks here? Who do we need to serve? Are we willing to give a higher capitated rate to this FQHC doing this wraparound work, and a less but still adequate rate to this private group of clinicians who only just do basic primary care? You know what I mean? Like, you could decide within a region how you would do that, and not everybody would get the same rate. And I think patients would still gravitate toward the clinics that are serving their needs, or the culture that they want to be part of. People, the way they choose medical care now. That's kind of how I would see it. Is that kind of what others were envisioning? The regional entity then would have to be like a default group for independent practitioners. There are a lot of independent practitioners, actually. I'm thinking about naturopaths, people that just hang a shingle out, people that are like solo providers or tiny little group practices, 2 or 3 people in a practice. The regional entity would sort of be a default group practice that would collectively represent all of those, and there would be incentives to be part of a provider group of some sort, but you would still be able to be like an independent practitioner.
I think Tony was next.
Tony, you're on mute. Can't hear you.
Maybe Mike, while we're waiting for Tony.
Yeah, it seems like Tony dropped. You want to move to Mike or Eve? Which way? Anybody?
Can anybody take?
Oh,
This is Eve. I can jump in.
Can
you all hear me? Go ahead.
Now we can. Yeah.
Sorry, it was the participant post. Apparently, I couldn't actually unmute. So I apologize. So I was going to save this for later on when it's the more focused discussion, but I wanted to come back to the comment or a couple comments related to kind of the effects of the groups. I work for an FQHC, and what I'm worrying about right now is actually we're going to be hurt potentially, probably pretty badly on this, because we get the RAP payment for both fee for service for Medicare and for Medicaid. So if we get a higher payment directly from the plan, we're still going to be made whole. But then on the commercial side, we're going to see a pretty significant reduction. So the overall will be a net reduction in our pay. Now, I've heard about wraparound services and trying to make us whole. So I'd like to understand a little bit better how we develop that. But I do have some concerns that the FQHCs are actually going to take it on the chin a little bit more. And I know that's kind of not the intent. The other thing I will add, just kind of as a high level, is I don't know if equating all payer means equitable care. I think it might mean equitable access, but the quality of care providers provide is based on HERC and their licensure and basically what the services are provided by the plan. And I don't really know kind of how much equitable care we're going to get from having an all payer. And it might be true or not, but when we see a patient in our clinic, the quality of care has nothing to do with the payer. They're going to see the patient, take care of them however it is. What services they get provided afterwards might be based on PAs or what the plans are offering, but the care we're providing is not going to change from payer to payer.
Can I jump in and respond to that really quick? Mike, I would just say that there is no situation where we would put forth a proposal for a plan that would harm the work that FQHCs do. That's my background. That's my, it wouldn't happen. But just to give an example, like we would look at what is the cost like right now, what does your FQHC get from Medicaid? What does it get from Medicare? What does it get from commercial? And what does it get from the wraparound payments? That whole sum, all of those things together would turn into your capitated rate, right? So it wouldn't be a reduction. You wouldn't lose your wraparound. It would be all of that money pooled together. You would make an argument to the regional entity and say, this is what it costs for us to provide care to the folks that we serve. This is the capitated rate that we need. And it would just be all blended together. But I can't imagine there wouldn't be a situation where we would put together something where we just lose the support that we give to FQHCs.
Thank you, Helen.
I think, Tony, if you're back on.
Can you guys hear me?
Yeah.
Yes.
I need a new computer. I'm sorry. I apologize for this. So a couple comments, and again, really appreciate the conversation here. I think just a couple observations is that, there's an existing constructs that we follow for payment. And I think one of the premises that the task force did was to maintain the integrity of the level of payment to all comers at this point, right? But I think that does warrant as we move into this investigation, right? Mike, I think your consideration is really important in looking at that. And, I think when you look at the level of, probably I would suspect your FQHC is supported by a lot of Medicaid, and thinking raising those rates, I think looking at that and keeping that whole, I'd be very curious if that didn't improve. I would just foresee a lot of FQHCs actually benefiting from this.
Yeah.
The other thing, a comment maybe I might make is that we have misallocated funding based off of geographic, off of equity. A lot of the community health clinics serve, BIPOC population that has been tremendously underfunded, right? And thinking about at this point where you have now a system that can look at, well, how should we allocate funding in a more equitable fashion to make sure that we're not underfunding certain sectors of certain populations. We now have the ability to do that with it. And that's actually one of the best parts of a single payer system. Back to the conversation about CCOs. It is a creative and innovative approach that we've taken as a state. And I think that, from the conversation that I remember in the task force is thinking about, do you disrupt that so much? Because there are a lot of value in the CCO structures. There are a lot of downsides to the CCO structures too. And it's looking at trade-offs of what are the pieces that might be of value to kind of continue to maintain with one big change, and that is a risk-bearing entity. And, as certain CCOs hold, maybe $1 billion in reserve, is that better to take all those together and make that a more efficient system? However, some of the information that comes from a CCO, like a CAC or a CAP, that actually is local care, is an entity that has value. So there are pieces that I think that we could look at that regionally, those are good demonstration projects that do, and going through the whole procurement process with CCOs right now. Some CCOs do this very well. Some don't do it as well. Some we're trying to improve upon that, but it is something that we might look to for some of those beneficial aspects to that. Maybe not wholesale, right? But I think that there is value in the feedback mechanisms to, Max's, point. I think the question of, will a third party as a CCO or a private entity want to, dive into that without having risk bearing, and is that bang for their buck? I think that's a question. Perhaps some of the CCOs would be still involved in that. Some would say that's probably not for us. That is a trade-off, right? But that might be something that we need to think about, how we support that and create investment for that, so that those groups can be productive in this environment to maintain the integrity of like what we're doing well. So I think there's just a lot of investigation. I think it's all good questions. The one other point I might make is that I'm not so certain that us buying into the totality of value-based care is the exact mechanism that we want to do. And I think this affords us an opportunity to evaluate some of the consequences of value-based care. So now there are some very good demonstration projects. We think that CCOs have delivered on return on investments because they deliver whole person care and focusing on that. But there are definitely some areas where we've moved into acuity panels and where we're having burnout among providers. And there is some areas and instances where fee for service has been beneficial. If we look at the Medicaid population of Connecticut, they no longer have managed care. They have all fee for service for the Medicaid population, and their rise in spending as a state actually has decreased. So there might be something for us as a group here to look at those different approaches. Certainly DRGs in Maryland is a perfect example for hospitals. That seems great. Anyway, I'm saying too much, just some thoughts and want to put it out there. I like the cat helping us out.
I think Chinwei is next, then Angela. Sorry.
Yeah, I just want to share some experience and complexity of global budget. Global budget is an extremely complex system and processes. And take Taiwan as an example. Taiwan implemented global budget since 2002, so it's been nearly 23 years. So it combined at the first level, it divided the whole services into sectors. So in Taiwan's case, they divided the whole budget into hospital inpatient, clinic and outpatient, dentistry, and then Taiwan has a unique traditional Chinese medicine. But then within those 4 sectors, they further divided into 6 regions. So Taiwan has a total population of 23.4 million, with 6 regions, meaning each region has about 4 million population. So each region is almost as big as Oregon. And so this is a kind of 2-layer of global budget. So you have a global budget by sectors, hospital, clinic, etc. And then each of those sectors divided by region. And then to complicate that, it's a fee-for-service system, except under the global budget plus the point system. By the way, the RVS get the principal idea from Japanese point system. Japan probably the first country to develop the value-based relative scale back in the 1970s. And Taiwan's universal healthcare's global budget also adopt the same system. So you have under global budget by region, by sector, and then each providers, they are paid on a fee-for-service system, but based on the relative value scale. So the beauty of that is each sector and each region, their budget is fixed. So if the provider over-provide, then each unit they provide gets lower value because the total, basically the denominator is fixed. So you have more points generated in the same sector, same region. Each point you get less money. And so that has been a very effective way of controlling costs. And of course, it also subject to annual negotiation. So usually around November, so each sector, they negotiate how much they should divide. But also they also negotiate how much the total global budget should increase. And in Taiwan's legislation, they kept at annual 4%, no more than 4% increase. And so each time they try to negotiate close to the 4%. So this is one way to do it, but there are many ways to do it. So if we are thinking about global budget, it's not just the global budget itself. There are so many other components, such as relative value scale and how we divide the sector, how we divide the region. Also, for the global budget to work, it will be difficult to start from the beginning year because we would need to have the empirical data to help us, to guide us how we divide the sector as well as dividing region. Thank you.
think Angela was next.
Oh, thank you. Yeah, thank you for those comments. It's really interesting to learn how other countries have evolved this. And I just want to echo some of the comments that were made already, and that the CCO model is great and yet imperfect. And so kind of going direct from the state to the providers, it does sound great because there's so much variation in content. And Mimi, glad to see you here. I know you from the Gorge and our CCO. And then, yeah, as far as capitation models, yeah, obviously they do offer more flexibility, but, value-based care, yeah, is also imperfect in some ways. But, certainly provided, in times of like a pandemic, right? And as you try to value other parts of the care team, right? It does offer and do other things besides the visit, right? And focus everything around the visit. So the provider visit, right? So it offers a lot of flexibility in that way and innovation in that respect. I'm not saying that that is a perfect system either. And then, yeah, I would just, coming out of Medicare being the innovation, and with making care primary getting totally obliterated from CMS and the Innovation Center. Yeah, we were excited about that, right? Investing more in primary care. And so, hoping that we would see that in this. And I agree with other folks talking about how while commercial is subsidizing in some areas, Medicaid is definitely subsidizing for FQHCs. And so for Mike's comment and Tony, you would see that equal. I agree with Helen that you would see that equal out, right? That there would be, other sectors are subsidizing others. And so we're hoping that this all payer would kind of equal it all out because, we're taking it for uninsured as well, right? So instead of managing to different payers, it feels less complex and less administrative too. I think I'm excited about all of this and hopeful, but we'll see where it keeps going.
I think
Helen, did you want to say something? We're in.
a long time ago. I don't know if you'd like to.
Yeah, I just wondered if you could explain how CCOs currently work in the sense of, does each CCO get a global budget right now? Is that a thing? Like, do we start with a single pot of money from Medicaid? I know CCOs are only Medicaid, but do they have Medicaid dollars at the state and then each CCO just gets a single amount from the state, or how does it work?
You're correct in that. The CCOs
get a global
so they have essentially, Oregon Medicaid has a global budget, right? This is the money for this year. And then they are divided up by the CCO regions. So then they go from there. And of course, some of the provider groups are in capitated care. There's even one of the large hospitals that has a capitated budget to operate on for their Medicaid members. But it's very different and all the CCOs are a little bit different. So it can be very different. But yes, you are correct. There's a pot of money. And so that's how CCOs, that's where the whole shared savings portion of the CCO can come in. Whereas if they come in under a certain level of money that is spent, then those extra dollars, depending on which CCO you're in, go back either to provider contracts, but usually it's like half goes back to the provider contracts, and then the other half might go to fund projects that the CCO has going on through the Clinical Advisory Council or the Community Advisory Council or the Clinical Advisory Panel.
And if a CCO is nonprofit, does that mean that they can't do like a shared savings? Like they don't profit off of it when they come in under their global budget. The CCO itself doesn't profit. They have to reinvest it, right? They have to give it back. They give it to the providers or give it to the community. They can't keep it.
Well, I should stop there. If they
not all CCOs are nonprofit.
Right. I'm trying to get to Tony's point about if there's not incentive, like what would be the incentive to be a regional entity? And I guess I'm trying to understand, like, I think some CCOs currently are like this nonprofit administrative, some of them are, right? That they don't take any money. If they do really well, the CCO doesn't get a profit per se, they reinvest it, right? So it can work, like there are people willing to do that. I know some, do we know how many are for-profit and non-for-profit?
I haven't looked at that for a while.
I think more are not for profit, but there are still a few for profit. I'm sorry, yeah, I don't have the exact.
I mean, yeah.
So if they're not for profit, what is their motivation to do that work? I mean, these are
they still have a margin. So for example, they would still have a margin that they would so an amount of money that goes back to that health plan. So even though they're and it's limited, though it's fixed, so they can't have a huge margin. There's rules around that. So that would be, I mean, that's the business of health plans, is to, you know, help deliver healthcare. So the money either goes back through shared savings, although I will say in some plans, if there isn't any shared savings and the health plan takes all the risk, in later years when there is shared savings again, they will then get that, they will take that margin back. They will go back and talk, you know, have it get paid, just so they don't, so it's a finite amount, it's not endless, but there is a model for that. But that's just, I'm sorry, because I'll just say that that's the model that I know best, but there are definitely other models, and I can't tell if Max is still on the call, but he might be able to comment.
Yeah, we're nonprofit and you have to pay it back. I don't deal with the finances a ton, so that's a little out of my area, but yeah, we are nonprofits. We can only have a certain margin, like it's like 3%, something like that. So yeah,
that's what it is.
Yeah, see, I don't know the numbers. I just know we gotta pay it back to somebody.
And what do you do if you come in under budget? Where does the money go?
It goes back. It goes back to the community. That's the shared savings model.
Back to the community, or back to the?
It goes to the provider contracts. Well, model that I'm familiar with. Some of it goes back to the providers as part of their contracts for meeting their metrics. Then the other goes into this whole shared savings things. The health council might decide what to do with it. It might go back. And then some of it might be distributed out in different ways. So there's, sorry, there's just such a wide variety of the way that different CCOs do things. Sorry about that informal rant, or not rant, but
no, that helps.
Yeah.
I mean, because the thought always is like the purpose of health insurance company, like, I mean, you know, just in the sort of cynical worldview of the business of healthcare, that the reason why someone would want to be in the business of health insurance plans is to make money, right? Like if they, like the whole managed care thing, and if they deny care or whatever, and then they get to take home higher profits, higher CEO salaries, like that model is the very business model. But we have an established model here of a regional entity as a nonprofit that then redistributes that money to the community, and that's something that could be built on.
Did we want to let Eve weigh in?
I think so.
Hand up for some time.
Oh, thank you. It's a good discussion. I think what comes to mind for me is the more we design the system similar to how it is today, probably the better accepted it will be initially, and we will have higher administrative costs. So every regional thing that we add where we have to fund staff around regions, every time we add contracting for providers that might be at different rates from other providers in their community, even adding acuity-based adjustments, you're probably looking at adding back costs for coders and lots of training for providers in how to document to maximize their payments for acuity. And so the savings that we would be looking at overall in the system would start to decline. So I think we just need to look at how much can we really strip out of the system in terms of administrative burden, and then what maybe is unacceptable to strip out initially and has to be done over time, but all of that will impact our ability to afford the type of model that we're talking about. I do, I run a primary care practice. We are fully capitated for primary care and Medicaid. It's a model that works very well for us. And a lot of that is because we can provide care for patients in the way that's best for them. So I don't have to have a provider see a patient. The patient can come in and get their blood pressure checked with a nurse and see a pharmacist, or we can just do a phone call. And we can do things that wouldn't normally be billable in the same way, which I really like on the primary care side. I don't see that capitation is taken off at all in specialty care. But you could look at, rather than fully acuity based, you could look at what lines of service does someone offer and does that impact their reimbursement rate. But the more simplified we can make it, the more of those administrative savings that we can have. I do like the idea of global hospital budgets. And that's because, right now hospitals are struggling terribly because they still rely on their surgical volumes. And what we want from a value-based care perspective is to move the surgeries out of the hospital whenever possible. And yet hospitals are motivated to try and court surgeons and bring those surgeries back to the more expensive care because that's how they pay the bill. They lose money on almost every other line of business. So having a global hospital budget could help to right size that. It could help us to move the money-making care out of the hospital when appropriate, because the hospital wouldn't have to rely on those volumes anymore. And they wouldn't be stressed out about their ER volumes, with the ER being a loss leader or any of those types of things that hospitals think about. So anyway, those are my initial thoughts. I agree with those who are talking about the special role that an FQHC plays. And it is really, a lot of it is the stigma that our patients receive in other settings, and making sure that we continue to incentivize providers who want to care for the underserved, because even if everybody's paid the same, there's still that sense of, I don't want to care for that type of patient, that is pervasive in the medical community. And I just want us to be thoughtful about that as an equity lens in how we support our FQHCs moving through this process.
Jamie, did you want to weigh in?
Yes, thank you so much, Eva. I really appreciate your thoughtful comments. There's one premise from the very beginning that I just have a tiny bit of palpitations about, and that is if we use Medicare as a starting point, I think we also need to understand that due to lobbying and political pressures, Medicare underpays primary care, which needs to be reimbursed better, and they overpay procedures, which need to be reimbursed less. And so if we can understand that that needs to be corrected, rather than just tying ourselves to decisions at a federal level that are influenced by politics that are different than our local politics. So it might be a starting place, but I'm not sure we want to have some sort of a corrective factor based on our values as a state to take care of our patients in a slightly different way. The other group that traditionally is underpaid is behavioral health services. And so again, making sure that we build those corrective layers in from the very foundation seems to me to be important. There's an idea around this, risk-based payment and critical access hospitals that might be helpful if we think about, as we're talking together in a few minutes, are there critical access services? and maybe thinking about the same sort of a model of a critical access hospital being supported in order, because for that region, the health of the entire region suffers if that entity goes away. But there also are probably some critical access services. Particularly, there might be some partialists, that's my word for people who are called specialists. There are some partialists which the state has a very severe shortage of. And so we might want to have some critical service support so that those remaining providers do not exit the state when their reimbursement drops. Because I think that's a predictable consequence for some of our subspecialty colleagues. The other piece that I've heard said a couple times, and I think there's already a structure to recognize the level of service of primary care using the PCMH structure. And so I think that can also help us to identify practices that are already showing they have wraparound services. And so we could instead of saying you have to negotiate at your region, if you are already participating in that and you've been designated that at the state level, you get a different reimbursement. You have to sniggle and argue and compete with the other people in your region for that.
Mhm.
All right, so I'm not sure who's facilitating today. Let's go.
I was just gonna say, I probably shouldn't have been so oblique in my comments about RBRVS, but RBRVS was originally introduced by and invented by Bill Shao, who was the mentor of one of the members of our group. And it was meant to redistribute toward non-invasive, less invasive, more cognitive services provided by healthcare practitioners. And in the political process, that got somewhat perverted, I think, mostly by the American Medical Association, who made sure that it got swung toward more interventionalist medicine. And so I think that's something you would have to consider as a state. Do you want to go through that whole process? And if so, how and what result do you want? But yeah, it is not a perfect base for valuing what you might value as communities.
So we have, looks like 2 more hands up, and I don't know how we're doing, Mimi, on time. I know we wanted to get a subcommittee together, potentially.
Yeah, do we, and let me interrupt for a second. Kim, do we have any public comment for this meeting?
We have one person signed up for public comment.
Okay, so we need to wrap up at 3:55 to allow for that. So we have 20 minutes left. And the only other task we have, is to find a subcommittee of willing people to kind of keep digging into this a bit more. So yeah, I think you can keep going.
Okay, so I think Betsy had her hand up next, and then
Yeah.
Robert.
Thank you so much. Mostly what I want to say is just express some gratitude for this conversation. I really appreciate it. And, sitting in the seat where I occupy for my working day, I represent physicians who work in FQHCs and those who work in independent practice. And what I hear is one of the aspects of the way our system currently is broken is everything Jamie just said, which is that the fundamental basis for the RVRU system has been tainted by politics. And I also, what I hear from my docs is things like, we can't afford to keep our community health worker anymore, or a care coordinator anymore, even though we're a medical home, because only one payer is paying us for that. And so, that is one of the things that that I hope that moving to this model will change. And I also want to tag back on something Jamie said too, which is that it'll be really interesting to see how this plays out in a marketplace for workforce. That if everybody needs to have really good care coordination, which in theory they all should have. Now, I'm not wanting to I want to acknowledge that there is a standard of care that we can and should expect from every primary care clinic, no matter what their patient population is. And I know that people, there just aren't enough bodies to do all of this work at the moment. And so there may be some, one of the things about disruption that we should be thinking about is what that's going to look like while we are shuffling the people who need to do this work. So anyway, thank you very much for this conversation. I really appreciate the wisdom of this group.
And Robert?
Can I ask quickly, is it possible to say which Milliman office is the consultant that's lined up for that work?
I don't think we know. Maybe Kim knows.
Yeah, they're actually based out of several offices, but primarily they're in the Wisconsin area.
Okay. Yeah. So having previously worked for Milliman and just in Seattle, and just to reflect on like Jamie's point and about the inequities again in the Medicare payment system, tainted by politics, and also Anya's suggestion that like actually if you do anything very different from that, it's going to be difficult to start pricing. Like I think that I think there are ways to address both of those concerns. Like the thing that starts to get really complicated in trying to price those things is if you try to make changes to the structures of the payment. Like whereas the way that say physician services are paid under RBRVS, there's a relative value unit and actually different like units for different things that comes to a total number of units, which is then multiplied by some dollar factor that like turns into a payment. And so even if it's probably too complicated to go in and mess with all of the relative value units or come up with what we think the correct relative value units are, it should be possible relatively simply to do something like vary the conversion factor for different, say, provider types that we think are under or overvalued. Like that's the kind of adjustment that would be very, very simple to make in the cost projection.
Okay,
then you'd have to figure out
to do that. Yeah.
then you'd have to figure out, well, the actual technical function of it is simple. Now then you'd have to figure out, like which provider types are undervalued and by how much or overvalued or whatever, and that is a more complicated issue. But for actually pricing it, it's not really messing with the structure of the payments to do that in a way that would make it technically impossible. And then I would just say that, it's important that we not talk about political pressures that existed like somewhere else some other time that don't exist here in Oregon for the process that we're like currently involved in. And so like important to recognize that all of the like we exist in the same political system. All of those pressures will still exist here in Oregon as the payment system is being developed. And I don't know if it's possible to safeguard, but just to be aware that like that is still a thing and it will happen here during all of this process.
Yeah. But even for you to know sort of how do you toggle the model is unbelievably valuable, because I think, a lot of what happens in provider payment is that it becomes so opaque that nobody knows on what basis are they being paid and how are they valued versus somebody else, some other service, their service versus somebody else's service. So
and just to say, this is my hesitancy, I think, on getting involved in some more LTSS work is, in fact, I know much more about this. So,
yeah, you're trapped now.
Probably.
You can take your name off the list. you're not you can choose.
Jamie had her hand up again.
Thank you so much. I just wanted to mention there was a piece that I didn't hear mentioned. It may be a sidebar or a parking lot item, But the other piece of how to reduce cost of provider payment is to address malpractice. And so like FQHCs have some tort protection. And if we have a single payer system, it does become possible for us to create some malpractice reform. And that might be able to be used as an incentive for providers who are accustomed to a very high salary in a high risk type of practice to be able to keep them in the state. You know, so yes, your income comes down, but you also don't have to pay astronomical malpractice insurance fees anymore. And so there, I just want us to remain open that there isn't just one direction to look at how to incentivize and create payment, but there's also ways to unburden maybe some other directions. So I'll let you decide if that needs to be factored in or maybe put as a sidebar or, you know, lovingly kicked to a different committee.
I think that's a great consideration that we hadn't put in the equation yet. So yeah, thank you for that.
And Dr. Chi?
Yeah, since Jamie raised one issue that we haven't considered, that just remind me of one more issue that Finance Committee have been considering and try to find a more accurate answer. That is, under a single-payer universal health system, how much saving we generate for the providers. And that will be a very important factor to consider how much we pay providers, because at the current complex private insurance systems, providers, clinics, especially hospitals, they spend a lot of administrative cost in doing reimbursement. And that will be substantially reduced. But the Finance Committee is trying to get a more accurate estimate. So that will be another factor to consider.
And I think Tony?
Yeah, just to say, I'm volunteer. I think I volunteered for this before, but just to put my name just to support this work.
So you'd like to be on the subcommittee of the subcommittee.
Thank you, Tony.
And I had already volunteered as well as this Jamie. I'm happy to continue there as well.
Yay.
So I don't know, Helen, if you want to try to get into any of we had a couple of the questions to possibly have some input on today. The first one was around the principles and the thoughts about that, but or the standardized fee schedule sort of approach, leaving the other questions for the subcommittee to consider, or we could defer all of them to the subcommittee.
Yeah, let's put those up because I think a couple of them we might be able to just look at the next couple minutes.
Kim or Mimi, can you get the slides back up? The first one had the 3 principles from the task force. And now that we've had this robust discussion, just looking at those, I think next slide. Was to try to get some thoughts about kind of what would be the principles, and this would be helpful to help guide the subcommittee. Their work is, this is what the task force had put down in their report. And if thoughts on whether this was complete enough, is there something missing? Is there something that should be removed? Any first blush thoughts, I think, Helen?
Well, I would add something about simple in there. I really appreciated Jamie's comments in there that whatever the system is, administrative simplification is a really core principle, that the more complicated we make it, the less savings, less the point of it is. Right? So that it should be as simplified as feasible. I don't know, like I'm not saying, I didn't hear this from the group, but I do think that if there are regional entities, that we should, as much as possible, focus on a nonprofit system, like having that if there are, if the global budget's being distributed to regional entities, that any regional entities should be nonprofit and reinvest in the communities. But I don't know, we can see if others agree with that.
Others have thoughts around these principles? It's like Mike, you got your hand up.
Yeah, thanks, Jeannie. So I brought this up earlier, and now that I read it, so it says resulting in more equitable care for patients, i.e. all payer rate. I.e. means that is. So I don't know if this is telling us it has to be an all payer rate and then discussion's kind of done, or if they're saying we want equitable care and an example that might be an all payer rate. I know it's a nuance, but if I were reading this and I was at a legal brief in front of me, I would think, oh, well, my directive now was all payer rate. Just, I want to make sure that that intent is clear and we understand what that is as we develop it.
How about EG?
Yeah, EG would be, for example.
I think I actually added that to try to summarize kind of what they were trying to say there. They ended after patients, but in the way they talked about it in the later area. But I think we've had, the idea would be, I think, is equitable in terms of aligning between the differences between commercial Medicaid and Medicare. But I think we've had a good discussion about how there may need to be some adjustments for a RAP for certain types of providers, so yeah.
Yeah, I think this bullet point was meant to get at more equitable access for patients, like the idea that people wouldn't be turned away because they had Medicaid instead of commercial, not necessarily equitable care, which I think was Mike's point. Is that right? Like equitable care is a whole different thing, but if everybody's showing up with the same card, so to speak, then they'll have more equitable access.
Yeah,
yes, that's right, hon.
They use the term care, so that's good to have the subcommittee think about these adjustments to these principles. Were there other hands up? Jamie.
I'm sorry, this may be a really dumb question, but with our discussion a few moments ago about eligibility, are patients with Medicare dual eligible by definition in this system? Or not? Are we just like saying as a state, we don't recognize Medicare? Or are people who have Medicare eligible for dual coverage, or do they just have, do we have one or the other? You have the Oregon plan or you have Medicare, and those are your only two choices.
So for what it's worth, I went through this exercise in Vermont, and it was a really important conversation because everybody says Medicare for all, and then they actually don't want Medicare for all because Medicare coverage is not so great. And so we priced it different ways. That Medicare coverage was Medicare coverage for people over 65, but that created some inequities. Then that the state single payer would wrap around Medicare, and that made it more expensive. So you may want to have that kind of slicing and dicing of your actuarial modeling to tell you that, because augmenting Medicare to make it the equivalent of a really good employer plan, for example, or a really good Medicaid plan at Medicare payment rates, or some multiple of Medicare payment rates, is really expensive. So I think those are the kinds of things you need to toggle, and that is a really a key decision because it's such a big chunk of the population. It's responsible for so much of the cost. And if you just assume they're going to stay on Medicare, then you've got a real equity problem.
Yeah, and I want this group then to keep that tension. I don't want Tony and I to decide it for you guys in our little tiny subcommittee thing. Like I really welcome the wisdom of the larger group with that type of a discussion.
Yeah, let me quickly jump in to share the information. The previous board meeting discussed related to this issue. That is, unless we get a total waiver from the CMS, otherwise the Medicare Part A will remain standalone, but the Part B and Part D, our universal health plan can become a carrier for Medicare Part B and Part D.
I think there were some more hands up, but do we need to move to public comment, Mimi?
We've got 2 more minutes, I think.
I was gonna say, we have a few minutes.
Your clock's
Could
different.
I just jump? Could I? Oh, I don't know if you guys can hear me. I'm still struggling with this microphone. You know, to your point, Jamie, I may be simplifying this, but in essence, it comes down to the benefits package, right? And as we decide, and it shouldn't matter, you know, where the money comes from does matter. But inevitably, what the experience of somebody on the Oregon Health Plan in designing this is that it would be just the benefits list, and that would be more comprehensive. So as we've theoretically outlined, it would be PEB and plus. But then if you are in an income area, so for like long-term services, we said, so if you were dual eligible for Medicaid, then you would have a broader scope of benefits, right? And that's how I would take, to your question and response.
Mike?
Yeah, this will be quick. Just, I wouldn't mind actually participating in the subgroup with Tony and Jamie, if that's still possible. When I heard them just say it was 2, I'm like, I wouldn't mind maybe joining them as a part of that.
Great, thank you.
Yes, please.
Okay.
Robert, you were waving like, yes, you'd like to join as well? Okay, so we've got a group of 4 now.
It was already on the list. Sorry, Robert.
That's right, by actuarial expertise. Any other volunteers for the subcommittee? Betsy, you got a hand up?
Yes, that's me volunteering.
Got it.
All right, group of 5.
Yay.
So there are some questions that we had put into the slide deck to just start the further delving into some of these. This again being sort of an intro first session on provider reimbursement, thinking about the standardized fee schedule. And then I think the last slide has some questions, again, just to help guide maybe the first meetings, and then come back to this group. All right. Betsy,
All right.
hand up.
I think you all timed that perfectly for Mr. Siniger to have his comments. Hello.
Hello. I bet you folks are getting real tired of seeing me show up every time you meet, but you really got to chore ahead, and I'm really impressed by the expertise and the knowledge that you all have and have laid out very carefully to one another. However, I wanted to talk about the university clinics that they have. I think you should look into that. And I wanted to talk about how CMMI was so inventive that they created upcoding so that the insurance companies and industry gets more money. But what I really want to talk about is the conversation that came up with profit versus nonprofit. I think that conversation is a red herring. I think it's a waste of our time. I have, as a consumer, watched Peace Health, and I've watched Pacific Source. Pacific Source is an insurance company, and in fact, a CCO with Trillium in the Lane County area. And I've watched Trillium and Pacific Source spend lots of money on advertising. I've watched Peace Health, who is really a regional hospital, spend a lot of money on advertising. But Peace Health is a nonprofit, and so is Pacific Source. Yet Peace Health closed down the emergency hospital in Eugene. But on the other hand, a few years before that, they had invested in a Zoom Care clinic that didn't, at the time, maybe they've changed, take any Medicare or Medicaid people. Pacific Source used their funds to buy other insurance companies, smaller insurance companies, and to spread their wings. So, you know, this committee and the governance board and myself and HCAO are all involved in trying to extricate a for-profit system into a care system. And it is very, very difficult. It's very difficult because we've all been raised under the profit system. It's just that now we have, investment companies and equity investment companies and insurance companies figuring out how much more they can make than what they're making now. So I don't know, just, would it be better? I mean, I think Eve Gray's attention to the administrative costs, the more that you can diminish administrative costs, the fewer codes that you need to have in the system would lower it. But just think of this. I know my time's up, right? But just think of this. What would happen if you just left the system the way it is now and said, we're going to pay 85% of the commercial rate and see where that would fall out, see what that would produce? And because 85%, you're saying, oh, well, the doctor, she would lose 15%, but don't forget, the administrative savings will be astronomical. They will be astronomical. I know there'll be at least 10%, if not more. So anyway, I really appreciate the work that you're all doing, and you're all 10 times smarter than I am. And I appreciate you giving me 2 minutes to say my piece, and I'll bow out at that. But thank you again.
Thanks, Lou. Any other final comments or reflections for the good of the group? I can't see hands if anyone's raising them, but okay, great. Cool. Well, thank you all so much for a great discussion. Thank you to our consultants, Janine and Anya, too, for your great work on this. And we will see you in June.